All right, great. So tonight's topic is falls under kind of men's health education. We're going to be learning about stress urinary incontinence. What is urinary incontinence? What is stress urinary incontinence? What are some of the coping mechanisms and treatment options for stress urinary incontinence? Um, as Chelsea said, my name is Dr. Jaspreet Singh. I have been practicing urology in the Hudson Valley for almost 8 years now. I grew up in Rockland County in the lower Hudson Valley and have come back to the area, and nothing's more special than coming back to your own hometown and in your whole kind of area where you grew up and to help the community that you grew up in. Um, and so I wanted to extend my gratitude to John, which we'll bring on a little bit later. John is actually a patient of mine, and there's I think no other way to um, thank a doctor than to spend the time out and kind of share their story. I mean, I'm really in debt to John spending the evening with us. I did my training here locally in Long Island. I did my medical school training. I spent a year doing an internship in Brooklyn at Brookdale Hospital, and then I did my residency over in Philadelphia and fellowship, and actually was on staff at Thomas Jefferson for a couple of years. It allowed me to kind of get comfortable with the academic setting before coming in to the area here. And I'm a firm believer of really providing the city level care in in our backyard, in our hometown. There's no reason why anybody should have to travel so far down into the city for their care. Male stress urinary incontinence. What is it? So incontinence in general is defined as an involuntary loss of urine, or simply put, leakage of urine. And there are many different kinds of urinary incontinence. Sometimes it can present with the urge to go find a bathroom quickly, something we call urge urinary incontinence. Other symptoms can include the need to use the bathroom frequently, uh, trying to find a bathroom perhaps every hour, waking up several times a night to urinate, and the leakage just starts occurring on the way with that urgency, that rush that you get to the bathroom. Stress urinary incontinence is a bit unique. Stress urinary incontinence, of course, stress, not necessarily in regards to mental stress, although incontinence obviously can cause a great mental impact, but stress in regards to anything that puts pressure on the bladder. And these maneuvers, such as coughing, laughing, lifting, bending over, pushing, pulling, day-to-day activities that can put pressure on the bladder. And because of the urinary sphincter, or a muscle that helps keep the bladder tight, due to damaged or weakened sphincter, the added pressure on the bladder causes the urine to leak out. And so I like to think about it as a balloon, and as every balloon has a neck that you can squeeze to help prevent the air from leaking out. So when you blow up a balloon, you can pinch the neck of the balloon and the air doesn't escape out. Now, if that pinch was weak, over a period of time, air will leak out. In the same way, urine from the bladder will leak out, and anytime you squeeze on the balloon, the air will escape quicker, and hence urine will leak out quicker. And so most of my patients will recognize stress urinary incontinence in perhaps their wives or sisters or things like that, their mothers, because it typically does occur in women. And that's primarily due to childbearing and after menopause, some of the weakening of the muscles in the pelvis can occur. And so men usually aren't affected by stress urinary incontinence. It's very uncommon for a man to experience leakage with coughing or sneezing or laughing. But men who undergo prostate treatment, whether it's for prostate cancer with having their prostates removed, or undergoing radiation therapy, or perhaps a resection of the prostate where the prostate has gotten too big and it's causing an obstruction, leading to a surgeon going in and, lack of better words, doing a roto-rooter and scraping the prostate from the inside out can sometimes damage the sphincter. And so in those men, when the sphincter is affected from prostate surgery, the incidence or the likelihood of urinary incontinence increases. And so when we look at the modern data, including data that most of what prostate cancer is treated with is robotic approach, it is not an uncommon entity. In fact, up to 15 to 20% of men a year after their prostate surgery will continue to experience urinary incontinence. And for most surgeons that talk to their patients about treatment for prostate cancer using the robotic approach or just surgery in general, will often quote data that looks at men who wear more than one pad per day. And so a lot of this data doesn't capture the amount of leakage men experience. And so I think that it's underreported. And in my own personal experience, being in the community here, even patients who go down to the city for their prostate cancer treatment or centers of excellence, they will also experience, a subset of them, difficulty with stress urinary incontinence. So that it's not an uncommon entity, but specifically in men who typically undergo prostate surgery. And so what is the urinary process? To understand what the sphincter is about, you know, the purpose of the bladder is to store urine, and it's to store urine until a person can find a socially acceptable way to empty it, hence being able to make it to the bathroom. And so the urine, when the bladder is full, it sends a signal to the brain that, hey, got to empty, I'm full. And so the urination or the micturition process or the voiding process includes the bladder squeezing, and so the bladder is a muscle, and the relaxation of the opening of the bladder, and then the urinary channel as it runs through the prostate. And so part of the relaxation that occurs is not only the opening of the bladder, but this muscle here called the sphincter. Now, our body has many sphincters, and it's not only the urinary sphincter, an anal sphincter, so that you're not incontinent of stool. There's a sphincter in the esophagus that prevents food from regurgitating after we eat. So there's many sphincters in the body, and this particular sphincter helps maintain continence so that leakage does not occur. And so typically, as the bladder is filling up, the sphincter is closed or remains closed, which allows the bladder to fill up. And so when the bladder fills up, that's where it sends a signal for the sphincter to relax and help empty the bladder. And so besides prostate surgery, what are other conditions that men may experience stress incontinence? Well, definitely neurologic disorders, a miscommunication of the bladder and the sphincter. Men who have Parkinson's disease or multiple sclerosis can experience weakening of the sphincter. Enlarged prostate. So it's not necessarily having the enlargement of the prostate, but I was just mentioning it's the treatment for prostate enlargement, specifically surgery or the transurethral resection of prostate, that when a surgeon is treating the enlargement of the prostate, he or she's using an instrument to basically remove the obstructing tissue in and around the urethra, and if not careful, can damage the sphincter. The distance between the prostate and the sphincter are within millimeters. So it does, it's not a common side effect of a transurethral resection, but it can occur and affect men anywhere from 2 to 3% after prostate surgery. Specifically the resection of the prostate for prostate enlargement. Even less common are pelvic radiation. And again, radiation, when it's given to the pelvis for prostate cancer, the surrounding tissues include the bladder, include the rectum, and so some of those tissues can get irritated. More specifically, I see this issue with men who undergo seed implants or brachytherapy for prostate cancer, because the proximity of the seeds, if they're placed too close to the sphincter, can damage the sphincter. And so finally, pelvic trauma, again, a rare entity, but men who are in a motor vehicle accident that have a pelvic fracture. and that pelvic fracture disruption of the bony pelvis can injure the sphincter, can tear the sphincter, and so another less common risk for developing urinary incontinence. And so what happens during prostate surgery, right? So I myself am robotically trained, and in fact, my training included oncology, or special time spent and extra time spent learning about how to manage the urinary tract cancer. So I myself do a lot of prostate surgery, and with the use of laparoscopy and robotics. And so in treating my own patients for prostate cancer, it kind of left a gap or a hole in the treatment algorithm of men who are undergoing prostate surgery. Now, again, it's not a common side effect, but things like erectile dysfunction, urinary incontinence are certain risks of having prostate surgery. And I myself felt as though, hey, I'm trained in oncology, in treating prostate cancer, but part of my training, or I should say, my training did not include how to manage some of the side effects of prostate cancer. So as an oncologist, my perception or my view was always about treating cancer. It was always driven by the fact that the PSA level should be 0. Well, of course, that's important. And as an oncologist, I value that the PSA level, obviously, we're taking somebody to the operating room. We want to remove the cancer that's present. But in the chase of doing that, in the race of getting the cancer out, we often forget as oncologists what effects of treatment, of the treatment that these, the men have to deal with. And so over a period of time, I felt as though for me to offer, again, kind of the best level of care, I needed to offer basically a whole comprehensive approach. So in sharing, and again, one of the beauties of being in the community is you get to share a relationship with patients. Oftentimes what's lost when you go down into the city where you become one of many, I think being in the community, you tend to have that relationship with the doctor, and I get to enjoy that relationship with my patients. So, I spent an extra time in kind of learning how to develop the training that's needed to do these procedures. So what happens during prostate surgery is that the prostate needs to be removed or disconnected from the bladder, and also the urethra, or the urinary channel. And so what's surrounding the prostate are very delicate tissue, primarily what we refer to as the neurovascular bundle. And many of my patients who research prostate surgery will ask me, Doc, what is this nerve sparing procedure? Well, what the surgeon tries to do during the prostate surgery is to try to remove the prostate by saving as much tissue that's surrounding the prostate. And so these nerves are important in being able to preserve erectile function. And so despite care, some of these nerves can get damaged. As you see, to remove the prostate, you have to remove some of the nerves that are adherent or close to the prostate. And so when the prostate's removed, the surgeon's left with the bladder and the urethra, and has to then reconnect the urethra and the bladder. And so that urinary sphincter we were talking about a couple of slides ago sits within 2 millimeters of the prostate. And so, of course, precision's needed. And so when we were looking at the evolution of robotic surgery, we had taken our patients from an open approach to a robotic approach. We felt as though, hey, this is the next greatest thing, because with the robotic approach, things are magnified. We can hone in on using the magnification and preserving the tissue that's around the prostate. But even in the best of hands, being as delicate of a surgeon, these side effects do occur. And so, as we mentioned, about 9 to 16% of men will experience urinary incontinence after prostate surgery. And so incontinence, or that loss of control of urine, will occur immediately after surgery. And that's typically the normal expected recovery after prostate surgery. When the catheter is removed, and the catheter is usually left for about 7 to 10 days after prostate removal. Once the catheter is out, patient may experience incontinence and may feel as though they have no control of their urine. And so one of the early interventions we discuss with our patients are something called Kegel exercises, which are pelvic floor exercises, essentially that sphincter exercise. And it's easy to recognize that sphincter. It's that muscle, as if you're urinating. You can stop the urine, relax, and stop. That stops the urine during the middle of your urination is that sphincter muscle. And so Kegel exercises are those exercises that you don't necessarily have to do while urinating, but initially to recognize what that muscle is and essentially squeezing the muscle through several times throughout the day. And so despite Kegel exercises, despite time, when we follow up with patients during their first year of recovery, many men will cope with urinary leakage in their own way, wearing pads or Depends initially, and so when we try to restore this quality of life, the next few slides kind of discuss what those options are in trying to regain that normal life, or as close to normal as things were prior to prostate surgery. And so urologists in general are doctors or surgeons that specialize in the urinary tract, both men and women. But there is something called a prosthetic urologist, and a prosthetic urologist is somebody who's taken an extra time to learn techniques and surgeries that are aimed at recovering some of the difficulties and complications of prostate surgery, specifically in this case urinary incontinence, and also for specific to prostate surgery or prostate cancer treatment, erectile dysfunction. And so initially, and sometimes indefinitely, I will have patients that will kind of change their behavior. Many of them will reduce the amount of water or fluids they're drinking. And of course, we know that that's not necessarily healthy. And of course, the understanding is that, hey, if I drink less, I will make less urine, and hence I will leak less urine. And so, understandably, but that may not be the healthiest thing to do. Often I'll have patients that will say, tell me that when they leave the house, they have essentially mapped out every bathroom along their trip to wherever they're going to, perhaps, going to the local bank. They know every little rest stop. And these planned bathroom breaks where they feel like they have to keep their bladder empty and having to urinate frequently. We talked about Kegel exercises in the next column here regarding what we can advise patients. So Kegel exercises do help. They're not a panacea. They're definitely not a cure for incontinence that occurs after surgery. In data or in literature, about 10 to 15%, realistically 10 to 15% of men will benefit just from Kegel exercises. And the reason is oftentimes Kegel exercises are, when we tell patients, listen, you need to work on squeezing this muscle, honestly speaking, most men are squeezing the wrong muscle. They end up squeezing their butt cheeks, and it's not really that sphincter muscle we're talking about. And so we try to encourage or coach patients in this thing called biofeedback. And biofeedback is essentially physical therapy for the pelvic floor, where the patient gets to sit down with a nursing staff and essentially learn how to squeeze the urinary sphincter and set exercises so that in real time you get to understand what muscle you're squeezing is truly the urinary sphincter. And of course, there are many coping mechanisms. I don't view this as treatment. To me, treatment would be kind of like fixing the problem. But coping mechanisms like wearing pads or Depends or diapers, many will resort to catheters, sometimes external catheters, what we call condom catheters that are placed on the penis, and so that the incontinence gets collected into a bag. And then sometimes using clamps, what I view as kind of barbaric, but it's a simple mechanism where something like a clothespin is used to squeeze externally or clamp the urethra or the penis So essentially what you're doing is you're squeezing the penis and essentially have to, go about your daily activities having this clamp. And it's not a small clamp, and can be obviously uncomfortable keeping that clamp on. So there are certain coping mechanisms patients will pursue. What can we do as prosthetic urologists, as surgeons of the urinary tract? So there are two main kind of long-term treatment options that are available to us and to our patients. One is called the male sling procedure, and the other one is the artificial urinary sphincter. And so the degree of leakage is very important in deciding which particular intervention would benefit our patients. Many men who have had radiation after prostate surgery, so that, in the instance where prostate's removed and the PSA level perhaps comes back or is still persistent after prostate surgery, a patient may require radiation therapy to the pelvis. And anybody who's had radiation after prostate surgery really should not be looking at the male urethral sling as a treatment option. I think if you're counseled in looking to pursue a sling, if you've had radiation to the pelvis, I think that's the wrong advice, and the data supports that. The success rates are not that good after radiation, and primarily because radiation affects normal tissue as well. And so when we're looking for the sling to heal and provide the support that's needed to regain the continence, it just doesn't work. And so we'll look into both of these entities a little bit closer. The benefit of a sling procedure, and why some surgeons may recommend their patients to consider a sling procedure, is that it's relatively easy to do. It's relatively quick in the operating room. The recovery tends to be quicker. It's a procedure that takes about 45 minutes, and it's a same-day procedure. And so the recovery tends to be quicker. The risks or the kind of investment that's needed to pursue that procedure is much lower than the artificial urinary sphincter. But again, what I was reviewing as far as the male sling goes, the degree of incontinence matters. So for men who have mild to moderate incontinence, and then we define that by no more than 2, perhaps 3 pads per day. So not depends, because depends tend to absorb more urine, but pads that are put on, and the 2 to 3 pads are not heavily soaked. So that mild to moderate degree of incontinence, those patients are better suited perhaps for the sling procedure. Men who have more than that, as far as incontinence goes, may be advised to undergo an artificial urinary sphincter. And so what an artificial urinary sphincter means is that where we recognize the own human body sphincter is damaged or weak, we're looking at a way to replace that sphincter artificially. And so there is a device or a prosthetic that's put around the urethra that keeps the urethra closed, and hence the bladder continence, so you don't have a leakage of urine. And so in fact, the artificial urinary sphincter is not necessarily reserved only for patients who have heavy incontinence, but men who also have mild to severe incontinence. So it really helps treat all sorts of incontinence that occurs after prostate surgery. All of the sphincter is an internal prosthesis, is nothing external, and really nothing that's on the outside of the body that somebody will or can see. Here's an animation of what an artificial urinary sphincter entails. This is basically a cartoon of the, oops, sorry, let's go back here. Just trying to pause here. And so here we're seeing the bladder, the urinary channel here, and then the artificial urinary sphincter. Now, the artificial urinary sphincter consists of 3 things. One is what's called a pressure regulated balloon. It's a small reservoir, less than an ounce of saline that's filled in the balloon. And this is tucked in right behind the pubic bone here, right in front of the bladder. A pump, what we call a scrotal pump, that's placed in the scrotum. And many guys ask whether that's going to interfere with any of the testicle. No, the scrotum itself is quite stretchy skin, and there's plenty of room to hide a scrotal pump, and it's a relatively small pump that's hidden in there. And the third apparatus is the sphincter itself. And the sphincter itself is now, as you see in this animation, is what's compressing the urethra. And so there's saline that's filled in this cuff, what we call, or urinary sphincter, this cuff. And so think about it like a pillow. And so this fills up with saline, so it's almost like a fluffy pillow that's surrounding the urethra and compressing it. And so when the bladder fills up, of course, that part of it is all normal. The signal to the brain is, hey, I'm full. The brain then tells the bladder, hey, you got to empty. And so that triggers a patient to then press the pump. And what this pump does is it pushes the fluid out of the cuff or the pillow. It kind of flattens it or empties it. And it pushes the saline out into the reservoir, which holds the saline. And so within a second or two, it empties the cuff, opens the urethra up, allows the normal emptying of the bladder. And so, typical urination perhaps takes 30 to 45 seconds to empty the bladder. And then the second part of it, to reestablish that cuff to close up, is an automatic thing. And that's where this reservoir comes in. It's a pressure regulated balloon, where the pressure within the balloon then pushes back the saline back into the cuff, and so that it closes automatically. And that whole process of it closing back up takes roughly a minute to minute and a half. So there's nothing that you have to press to activate the sphincter again. So the only thing they have to do is to squeeze the pump to deactivate the cuff, open the urethra, let the bladder empty, and then automatically over the next 60 to 90 seconds, that cuff closes up. And so, why do we take the time out to talk about these things? As important as it is to cure cancer, the constant reminder of having the diagnosis of prostate cancer, in changing pads every day, in having embarrassing situations where you're, in a meeting and a heavy cough results in leakage or spotting of the pants, is embarrassing. And not only embarrassing in keeping men to regain that confidence to leave the house, but also, to reestablish sexual relations and intimacy. Many men that undergo prostate surgery will report leakage of urine during climax. In fact, the entity is called climaxuria, where it can be embarrassing, even if one has been married to their spouse for many years. Having leakage during sexual activity is often a very embarrassing situation. There's a great website here. I'll share with you guys two websites. My own personal website is www.singhurology.com. That's www.singhurology.com. A lot of good information on that website. And in particular, regarding urinary incontinence, what we talked about this evening, www.fixincontinence.com. Two great resources in learning further about how to manage urinary incontinence. It's often something that's not talked about, talked about, period. It's something that's embarrassing, and also along those lines, guys who struggle with erectile dysfunction after prostate surgery, it's something that should not be a secret under the sheets, so to speak, and something that, as prostate cancer survivors, we should all kind of talk about to try to resume our normal day-to-day life. Of course, with any sort of surgical procedure, there's risks, including the decision to undergo prostate surgery for prostate cancer. But the rewards that we get with removing the prostate, there are certain risks, and so with these surgeries as well, there are certain risks to these surgeries, and they're all kind of low. In the good set of hands, the recovery tends to be relatively easier for the sling procedure. For the artificial urinary sphincter, the procedure itself is something that takes about an hour, 15 minutes to an hour and a half in the operating room, typically an overnight stay in the hospital. And then We give it about 4 to 6 weeks to let everything heal up, the swelling to get down, and we keep the sphincter open or deactivated for those 6 weeks, and then in the office in 6 weeks to educate our patients on how to start cycling or using the device at 6 weeks. As with any surgical procedure, infection and expected bruising and swelling is all there. The things that are unique to the artificial urinary sphincter is that imagine wearing a collared shirt and the top button being a little too tight. And so the sphincter kind of works like that. It's keeping the urethra compressed and keeping it tight so that doesn't leak. But that can get uncomfortable, as though that top button being a little too tight. So it feels sometimes nice to just unbutton that top button. I educate my patients to open up that sphincter. Typically at nighttime, most men are not as incontinent at nighttime, so that it helps open, let that urethra breathe, let the kind of the top button loose, and reduces the risk of erosion. And erosion is when the device itself can basically cause atrophy or weaken the urethra and migrate through the urethra. It's not a common risk, but something to think about down the road. The urinary sphincter has over 90% success rate, has over a 90% satisfaction rate. And the likelihood of revision at 5 years after surgery is somewhere around 10%. And so the other questions patients ask is, because these are kind of quality of life issues, whether insurance covers it. We've been doing incontinence procedures for over 25 years. In fact, the artificial urinary sphincter has not really had an update over the last 2 decades, primarily because of how good it works and the ingenuity of the mechanism of the device. Insurance companies cover this, Medicare covers this, and most private insurances. So often a question that's asked, and of course we work with all insurances to make sure that the procedure is justified, and we work on getting those approvals. So I'm going to end my part of the talk, and I appreciate your attention in that. We'll answer some questions kind of at the end. I wanted to get John on, and so that he can share his kind of experience. He is a prostate cancer survivor, and we kind of need to kind of understand what he went through with his diagnosis and kind of what his recovery was. So I'm going to stop my screen. This is our information here for anybody that wants to jot it down. We just moved into our new office on Little Britain Road in New Windsor, and that's our phone number to get a hold of. I also have an easy phone number to remember. Didn't get a chance to put it on the slide. It's 1-833 Dr. Singh, 1-833 Dr. DRSINGH. Kind of easy to remember, and can put you through to my office. All right, John. If I'm going to put you on here. I think you're unmuted. So the stage is yours, bud.
All right, just want to say hello to everybody. I want to say hello to Dr. Singh and thank him or his office for giving me the opportunity to speak. I am a patient of Dr. Singh. Just a little bit about myself. Right now I'm 58 years old. Back in 2017, I was diagnosed with prostate cancer. I had the surgery, prostatectomy, robotic prostatectomy, in the March of 2018. I did all my Kegel exercises after, and I still had incontinence. I went through the biofeedback, did that program, and I still had incontinence. And my incontinence was it was a lot. I work outside in a strenuous job, and I was wearing Depends and pads, easily 6 pads a day, if not more. The only time I didn't have incontinence was when I was sleeping. I could wake up and I could make it to the bathroom and go, or if I was sitting down in a chair for a while, I could get up and go to the bathroom and relieve myself. But anytime I was walking around or, during the day, I couldn't control my urine. So in like October of 2018, I heard a radio commercial, and it was about Dr. Singh having a seminar down in Fishkill, and it was for incontinence, and it was also for ED. I went down there. I listened to his, seminar. I really liked him. I knew what he was talking about. So I followed up by making an appointment, and I went in, had a consultation with him, and from there, I ended up deciding on doing the artificial urinary sphincter. I went that route, and so in January 2019, I had the surgery. The surgery, you go for overnight. You're definitely in some discomfort. Your testicles, your abdomen a little bit, down below your testicles, between your rectum and your testicles. It's one of the incisions that they make. So it's definitely, not the most comfortable thing, especially sitting down. Went home, and he said, we'll see you in 4 to 6 weeks for once it's healed. So I went back in about 6 weeks, and that's when he activated the sphincter and showed me how to use it. And I tell you, it changed my life. It's been the best thing for me. I went from, basically from depends and 6-8 pads a day to being normal. It took a while to get used to. It's a little bit of adjustment. You have to, you can't use your, you have to pull your underwear all the way down and all, and finding the button and all that. It took a little bit of adjustment period, but since that time, it's been great. Occasionally, like the seam on your pants, if you're sitting down and the seam might catch the button a little bit, push it once, and you get a little spot. But for the most part, I wear one pad during the day at work just for security purposes, and that's all I wear. And 99% of the time, it's never soaks through or gets wet. So my quality of life is it's just a turnaround, 180 degrees. And I'm so thankful that I went through there, and I went and saw him, and I talked to him, and it just turned my life around. I appreciate it.